Hi, my name is Alejandro Delek. I am going to talk about manual therapy in the treatment of myofascial pain related to temporomandibular disorder. Definition. The temporomandibular joint is a joint influenced by different factors that can trigger different symptoms such as a pain, functional impotence, and joint limitation. Triggering factor can be microtrauma, macrotrauma, abnormal occlusion, uh, abnormalities of the articular disc and articular surface. Parafunctional habits such as bruises, existing stress and organ condition can cause inflammation, capsular termite, pain, or muscle spasm.
The temporomandibular joint, the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back ends of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
Application in physical therapy. From the point of view of physical therapy, there are many techniques that allow us to obtain excellent results. Massage, stretching, joint mobilization, myofascial therapy, relaxation exercise, osteopathic manipulated therapy, thyroid treatment, global postural relocation, electrotherapy, dry needling, acupuncture.
Hi, I'm Rebecca Petrosino, a physical therapist at Physical Therapy and Sports Medicine Centers in Fairfield, Connecticut. And I wanted to talk to you today about physical therapy for the TMJ or temporomandibular joint. That's an area that people often don't think of when they think of physical therapy, but it is an area that can be very helpful to treat headaches, jaw pain from clenching, grinding, maybe a bite malalignment, or muscle spasms in the jaw from stress or anxiety. So today I'm just going to show you a little bit about what we do in physical therapy to treat that area. What I may do is ask the patient to open and close. And I look for whether or not the movement is symmetrical, if there's any popping, clicking, or pain with that movement. I'll also ask them to bite down and assess whether or not the muscles in their jaw are either tight, tender to touch, or cause pain when they do bite down. So next what I'm going to look at is your side-to-side movement of your jaw. So I'm going to shift side to side, and I'm going to look for symmetry and again popping, clicking, or pain. And next what I'm going to do is look at the tenderness in the muscles as well as how the joint is moving in a more relaxed position. It's more comfortable for the patient and I can really get a look at the symmetry of movement. So one of the things that we look at is opening and closing pattern. Go ahead and open. And I look to see if there is popping, clicking, and whether or not the joints are symmetrical on the left and the right. And I'll also look to see if there's an abnormal pattern of movement. There can sometimes be what we call a C curve, where the jaw deviates out of position and ends up back in neutral, or an S curve, where it's asymmetric throughout. You can also have the jaw deflect to one side or another. Go ahead and open. So if the jaw deflects to one side, that usually means that that is the side that has some restriction. The next one I'm going to do is mobilize the TMJ. So if I do find restriction on one side, what I'm going to do is place my thumb on your bottom teeth. Go ahead and open. And then let your jaw be nice and relaxed. And I have a grasp on the jaw, but she's comfortable and relaxed, and I'm palpating the joint here to see what's happening and giving a nice stabilization. And then I'm going to move that joint and assess the mobility there. We can decompress a joint that is tight or restricted, and if somebody has limited opening, I can mobilize that joint to facilitate a better movement pattern. So another thing that I can do to try to relax the muscles of the jaw, go ahead and relax your jaw, but teeth not touching, perfect, is I am feeling some of the muscles on the inside of the jaw as well as muscles on the outside of the jaw, and you can just do some soft tissue mobilization to release muscle tension and to treat the muscles that have tension from clenching, grinding. And sometimes patients have appliances that they wear at night, and that does not necessarily mean that they would not benefit from physical therapy. Sometimes people who have a night guard still tend to clench on the night guard. It protects their teeth by having the guard, but it doesn't prevent the muscle tension. So regardless of whether or not they're having splint therapy, they may still benefit from having physical therapy. So we can also address the temporalis muscle. In that case, we can do some soft tissue mobilization to the temporalis. You can do some myofascial stretching of the temporalis by engaging the mandible or the jaw and providing a gentle stretch. Alright, so next what we're going to demonstrate is dry needling of the masseter, and that is a muscle in the jaw that is commonly tight or can have muscle spasm with clenching and grinding. So you feel in the muscle for any tight bands in the muscle or trigger point in the muscle, and when you find an area that needs treated, You're going to insert the dry needle, and then you can release the trigger point. And there was a good twitch right there. And that's all there is to the masseter. You can also perform dry needling to the temporalis, which is a muscle that can be involved with clenching and grinding, but it can also be affected with headache conditions. And again, you're going to palpate in the temporalis muscle and find any taut bands or trigger points, areas of tenderness and tightness. And release any of those trigger points. Okay.
That felt good.
Pros and cons. Pros. Manual therapy on TMDs decreases headaches, increases neck functionality. Similarly, treatment directed at the cervical spine decreases pain in TMD patients. Cons. Manual therapy has no negative effect on patients. Statistics in Ecuador. Temporomandibular disorder is very frequent problem. Approximately 17 to 19% of the general population has at least one clinical symptom, while 5 to 15% is no clinically significant symptomology. It is considered a disease of modern society. In Ecuador, a study conducted in the population of Cuenca was able to determine that there is a prevalence of 16.8% of the weak deficient or disorder of the temporal mandibular joints. This being a considerable percentage at the time of intervening in the treatment of this pathology. Conclusion. Manual treatment significantly improves TMD symptoms, especially osteopathic physical therapy, both joint and soft tissues. Similarly, action on the TMD improves cervical spine symptoms. Manual physical therapy alone improves TMDs that do not require surgical intervention. Finally, the symptomatic review analysis recommended further study on TMD and their physical therapy treatment.